Kei aku rahi, tēnā koutou katoa. Ko pololo gali taku ingoa, kei waipapa taumataro, aho I mahi ana, hei ahorangi, ohana, hoora. So following the theme of diversity, I've just introduced myself in Te Reo Māori, which is the Indigenous language of Aotearoa, New Zealand. What I said in English was hello to one and all. I want to acknowledge the size of the crowd and the importance that sits here today. My name is Paula Lorgelli. I'm a Professor of Health Economics at the University of Auckland. So I have the pleasure of moderating this final plenary, which is about reframing health economics in the context of climate change. And before we start, I wanted to borrow another Te Reo Māori word, which is kaitiakitanga, and that's the concept of guardianship and protection of the environment. And it encompasses the view, which according to Google, is not unique to Māori, and I think actually it resonates with many Indigenous people, that we don't inherit the earth from our ancestors, but in fact we borrow it from our children. So in the notion of kind of borrowing, preserving, and leaving a health economics legacy, we have three presenters today, which will provide a call for action to health economists to consider the changing climate and the growing threat to planetary health in our research. So we have the pleasure, again, under our theme of diversity, of welcoming an environmental economist. So Professor Liz Robinson is beaming in from the London School of Economics and Political Science. And we're welcoming her into our health economics space to understand what we can learn from another subdiscipline of economics. We will then have two health economists, Professor Joe Borgi and from London School of Hygiene and Tropical Medicine, and Professor Martin Henscher from the University of Tasmania, to provide some further insights from the lens of health economics. There will then be a panel discussion, and I'll welcome comments and questions from you all, as well as some other thoughts on how do we encompass and how do we think about health economics and our changing climate, and making sure that we contribute and preserve and leave for our children something more than what we've perhaps currently got today. So over to Liz, hopefully.
Thank you so much for welcoming me into your space. I wish I could be with you in Cape Town. I used to live in Tanzania, and I raised my kids when they were small there, and I've spent many a great time in South Africa also. So I'm sorry I can't be with you, but thank you so much. Yeah, I'm really excited to be a part of this, actually, because I think we had some pre-conversations before this panel and realized that, there are sort of two separate worlds of health economics and environmental economics. And there's a space where it could be quite exciting for us to work together. So what I just wanted to talk about, I think a presentation should take about 30 minutes. So what I wanted to talk about was first, very quickly, who's talking about what, where in this climate health nexus or space where there might be space for economists. And then I want to talk a little bit about the work that I'm involved in. It's funded by Wellcome Trust, and it's called the Lancet Countdown on Health and Climate Change. And there's not a lot of economics in it, but I think it's a really good starting point for where us economists that can think about where there might be some important entry points for us. And one of the key things is we track in this the links between climate change and health, but we also look at the health co-benefits from climate action. And then just at the end, I just want to talk a little bit about what the implications of this are for environmental economists and health economists working closer together. And hopefully in our panel discussion and the questions, we'll have a chance to sort of go a little deeper into that discussion. So just to start with, it seems reasonable to ask ourselves, who's talking about health and climate change? So this is some data from the Lancet Countdown, and it looks at the United Nations general debate. And not surprisingly, people have been talking about health for a long time. Climate change, there started to be discussions in the sort of early 90s, but it's only really in about 2005 onwards that climate started to figure much more prominently in UN discussions. And we can see, the number of mentions are sort of on a par with health. And then if we think about the intersection of climate change and health, it pretty much didn't exist. And we start to see a little noticing in the early 2000s. And then sort of 2015 onwards, boom, suddenly there's a lot of discussions. And so this is a bit self-referential, this slide, but in the Lancet Countdown, we think we can actually take some credit for that, because we've been using our work to really press a message, especially in the COP meetings and in any sort of international government gatherings, about how important it is to think about the links between health and climate change. I'll talk about that a little more. So let's see who's writing about health and climate change. So again, these are data tracked by the Lancet Countdown. And what we can see is there's an awful lot about the impacts of climate change. Again, sort of starting about 2004-05. And these are scientific journal articles covering climate change and health. But a lot of it is the impacts, as I said. So that's kind of where the science sits. So we can see there's an awful lot of science being done linking climate and health. But when it comes to actions and what we can do to tackle climate change in the context of talking about climate change and health, we can see there's very little on adaptation and very little on mitigation. And if we think about it, that's really the space where we would expect to see social science, where we would expect to see economists. And so it looks like there's quite a lot of catching up for us to do in that respect. And we could argue that the science is pretty much settled. Of course, we can have better science and we can explore in more detail those links between climate change and health, which is what my working group at Lancet Countdown does. But that's sort of fine tuning, where I think in mitigation adaptation, there's huge gaps. And I'm hoping that us, who are interested in this session this afternoon are going to try and fill some of those gaps moving forward. So if we just look at sort of news and social media, 3 of the top 10 climate papers in 2021 addressed climate change and health. And number 8, so I'm pointing at my screen like you'd see me pointing like I'm here with you. But number 8 is the 2021 report of the Lancet Countdown. And so again, climate change and health very much coming sort of front and center in this decade. So the next 2 slides are very unscientific. But I just thought, given that I'm an environmental economist talking to health economists, I'd look and have a quick look at what's happening in our journals. And the straight econ journals. So I looked at Journal of Health Economics and I looked at Health Economics Review. And I just did a very simple search. Obviously, they all mention health, but I did a simple search of climate change, and that didn't come up with a lot. So the ones that are climate change, we've got in the dark purple and light blue. But this comes up to some extent. And then I looked at just climate, which gave a few more mentions. So not a lot of interest, particularly we could argue, about 5 to 10 articles a year max. And I thought, okay, look in the straight econ journals, which I knew the answer to, but there's very little attention to climate change or climate. And again, unscientific, I just looked at Journal of Political Economy and the AER to see if there's any discussion of this. And so I thought, well, I know there's lots of economists who are talking about health and climate change. Where are they? And so they are, but of course, I kind of know where they are because I work with the few that there are. But I sense very much it's the environmental economists who at the moment are filling this space. And so again, unscientific, I just went with GEME, which is Journal of Environmental Economics and Management. It's one of the sort of most aspirational field journals, I guess, for environmental economists. It's the European Journal. And here we can see in yellow and green, a lot of attention to climate change, a lot of attention to health. And actually in red, we can see about 10 to 20 articles a year, just in this one journal alone, looking at climate change and health. And it seems that's kind of where those of us interested in climate and health, we tend to be looking at environmental economics journals, or, we'll be looking at journals like sort of, Lancet Family, or some of the more health journals. Then in terms of economics field journals, the environmental economists seem to be more interested in this space. And so there's tons of space for other disciplines and other field disciplines. So as I mentioned, I work on Lancet Countdown, and I wanted to just show some of the data from this. Some I've shown already, as I mentioned, because I was showing the sort of working group 5 who are tracking, allergies are bad this year, which also is sort of being driven by climate change. So excuse me for not having mine under control. So in 2005, the Lancet Commission concluded that anthropogenic climate change threatens to undermine the past 50 years of gains in public health. And I think this statement alone makes any of us who are interested in public health and public health policy sort of start to think, well, we really should be seeing how climate change might be affecting everything when it comes to public policy and how it is. That's a sort of depressing message. And so there's been quite a conscious effort by quite a lot of people to try and flip a more positive message. Not that we're suggesting there's much positive at the moment in the future with climate change, but the more positive message is that clearly if climate change is threatening health, then there's a huge opportunity through tackling climate change to be a tremendous health opportunity for the 21st century. And you might have sort of seen it in the headlines or heard people talk about it, but a lot of people say that the health of a child born today in the 21st century is going to be determined by whether or not we tackle climate change and get it under control. And so we start to think of this concept of health and health policy. Maybe we need to broaden our sphere of what a health policy is. And it may not just be in terms of the sort of Ministry of Health. And so what the counter does is to some extent, it's very simple, but it's quite complicated to do it. But we track indicators that show links between climate change and health, trying to identify those opportunities. And I'm just flipping back for you guys the slide I showed earlier, but again, the mitigation, the adaptation, the real space where I think there's scope for economists to have some contribution. So how do we translate this into action? I think many of us who work in the sphere of climate change, we like to get good publications, but what we really want is to feel that we can have an impact and that we can contribute somehow to climate change mitigation or climate change adaptation, or more broadly, building resilient societies that are on track for net zero by 2050. And so we need really clear, credible messages that support action. And for that, I'm an economist, so I'm biased, but I do think we need the economics to allow policymakers to start looking at where are the best investments to be made, and to what extent we can start to change that risk profile for our health when we look at the climate health nexus. And again, like I said, probably we need a broader conceptualization of the health policy arena. So this is a complicated diagram. I'm probably going to put up too many complicated diagrams, but the idea is just to show our starting point for the Lancet Countdown, recognizing that the climate change hazards are reflecting in sort of extreme temperatures, altered rainfall patterns, ocean acidifications, and they're very complex pathways through which that mediate the impacts on health. Some are more straightforward. In a heat wave, we know that people are going to be particularly harmed who've got pre-existing conditions linked to cardiovascular disease or respiratory disease. We also know, of course, that health outcomes are mediated by social determinants of health, and there are some we've listed here, but a health economist might be more looking at access to healthcare. I don't know. And then, of course, the other impacts on health outcomes are the causes of climate change. So particularly, for example, burning fossil fuels. And so the air pollutants are feeding in as well. So it's a complex diagram. And what we try to do is take this and kind of provide some simple metrics. So for that, we try to quantify and track the links. And here's just one example of some of the data we use. And I'll just go through sort of 4 or 5 slides showing some of the elements of climate change and health links we track, and then keep bringing it back to the economics where we can. So in working group 1, which I lead, we're tracking these impacts. And so we start off with the hazard, the climate hazard. In this case, we're looking at temperature. So we're using ERA5 reanalysis data, ERA5 land reanalysis data. And so we can think of, I don't know if you can see me, so I'm doing all kinds of gesticulations with my hands, but we have these layers. So the first layer is our climate hazard layer, in this case, heat. And then the next layer, in this case, is population density. And so what we can see is that the planet is warming. And so the orange line is the extent to which the planet is warming over the landmass. And then when we look at the extent to where the population is, we can see that the population tends to be more dense in the areas that are warming more. And so we get this amplification of the impact of climate change when we link it to actually people and therefore health outcomes. So that's one of the indicators we plot. Another indicator we look at, this is a slightly more sophisticated one, is we're looking at the extent to which temperature influences labor supply. This is work done by Dr. Shura Dasgupta in CMCC Venice, who's a co-author of mine, and we work together on the countdown. And what we can see here is that there's a nonlinear relationship between temperature and labor supply. And so in most European countries, we're on the right-hand side of the optimal temperature. So when there's warming, that reduces labor supply. In a few countries in Northern Europe, when there's warming, it actually increases labor supply. And we can start to calculate to what extent a change in labor supply can be attributed to something linked to climate change. And in this case, we're looking at average temperatures, but we could also look at heat waves, for example. So what's this got to do with health? Well, there's several aspects we can look at. We also look at a global consideration of the potential work hours lost due to extreme heat exposure. We get big numbers, 295 billion potential hours of work lost. And we can look at to what extent this is a problem in low Human Development Index countries, sort of a bit of a proxy for poorer countries, LMICs. And then I've just compared and contrasted with very high Human Development Index countries. That's our very much higher income countries, OECDs, European. And we can see, for example, that in agriculture in low HDI countries, it's particularly problematic in terms of warming and climate change. What we can see over time is just the extent to which there's increasing numbers of potential hours lost. So this is a health issue for many reasons. Working in extreme heat is linked to cardiovascular and respiratory disorders. We know there's increasing concerns over links to kidney disease. So there's started to be a lot more information coming out in the popular news, but also people are starting to do some rigorous research on it, that agricultural workers are increasingly discovering they're suffering from kidney disease. It looks like that's a combination of heat exposure and dehydration. And then if you've simply got loss of earnings from not being able to work, you can't maybe afford to protect your family and provide health coverage. It's also an economic issue because this puts pressure on health services. And indeed, it's an economic and health issue if there's potential lower productivity in health service workers. So if health service workers are protected from extreme heats, and especially, for example, in low and middle income countries, then we might see poorer health outcomes for people needing healthcare, and we might see healthcare workers themselves suffering. And there's likely to be a long-term impact on economic growth. And indeed, Schroeder has been crunching some more numbers for us. And what he is finding is we can start to pick up a real fall in GDP per capita growth that we can attribute to annual temperature anomalies. So this data is specific to Southern European countries, which again, remember, temperatures are already above the optimal for those countries. And I suspect if we repeated this exercise in low and middle income countries, we would probably find something similar. So that's sort of, I focused a little bit on some of the hazards, the climate hazards, how they're linked to population. We can start to look at some attribution. It's also important from respect of sort of broad healthcare and broad sort of health outcomes as to who and where the most vulnerable are. So we know that those most at risk from heat waves, for example, are the very young, the very old, and those with pre-existing health conditions. So in this graph, and this is just pure numbers, so we're not surprised that countries with large populations have a large number of population at risk. And, we can recreate this graph if we want to for per 100,000 of population. It really depends what we're trying to look at. But in terms of where are the vulnerable babies in terms of volume, we're very much looking at India and China. So here again, we're overlaying population of infants under 1 with heat waves. And what we can see over time is there's really been quite a big change from 2009, 10 onwards. What these data are picking up in is both population growth and growth in heat waves. And so if you want to explore our data on lancetcountdown.org, you can start to deconstruct this and say, to what extent is this population growth? To what extent is this increase in infants in particular? And to what extent is this increase in heat waves each year? We have data for all of that, so you can disaggregate it. And then if we're looking at older people, it's very clear that in terms of volume, we're looking at Asian countries. And why is that? Well, these are aging populations. So these are large countries with aging populations. And certainly if you look at what's going on in terms of in Asian countries, we see that there's real concern about healthy aging more broadly, because these are aging, shrinking countries. So there's a high dependency rate now. The number of people of working age supporting the number of older people that ratio of old to working age is growing. And of course, with the pressures of climate change, these are the people who are most vulnerable. So healthy aging is important for two reasons: climate change and the changing demographics of these populations. And I'm working on this with Alice Bien, who I think is listening in from an office near me. So she and I are sort of trying to really focus this work. So if there's anyone interested in the situation in Asia, I think healthy living, climate change, and health are a really important area there. This is another example of where we can attribute outcomes. This is work Shura Dasgupta and I are doing together. And here we can start to attribute the extent to which increases in food insecurity can be linked to increasing heat waves and increasing droughts. If anyone's interested in the details, we use the FIES Food Insecurity Experience Scale. It's data produced by FAO, and it's about people's experience of food insecurity. Here we're looking at moderate to severe food insecurity. So that includes people who feel they can't get enough to eat, they can't get enough variety. And we can pick up now how increases in heat waves are affecting food insecurity and decreases in drought. Now, people who work on food production might expect to see drought having more of an impact because it has more of an impact on food production. But what we're seeing is that food insecurity is being affected not just through food production, but through people's ability to afford food. And that might be because heat waves are affecting people's earnings. Heat waves might be affecting people's the cost of food and therefore affordability. So there's quite a lot of complicated pathways through which this might occur. Okay, this is one of my most painfully over-the-top figures, but don't worry about the details. I'm going to overlay. But we also look at health outcomes in terms of under 5 mortality, stunting, and wasting. So these are data that we've looked at for Burkina Faso. And what we find is the graph on the top right shows that there's warming. So again, this is one of the layers we use. The graph on the bottom right is showing that crop yields are plateauing. And we might be asking ourselves, is that due to climate change? Or is that due, for example, to exhausted soils that just need improved fertility? But when we run the econometrics, and this is a complex sort of panel data, what we find is that we can find links to wasting in terms of the socioeconomics and in terms of these increasing impacts due to climate change. So not surprisingly, if we look at the wasting outcomes, delivery in a health facility, access to health facility matters, mother's education matters, access to health and sanitation matters. But also we're finding that precipitation and temperature matter too. So, I think this is really very much at that sort of nexus of health economists, environmental economists, and climate change economists, that we're seeing this intersection of access to healthcare and the impacts of climate change. So some of the win-win opportunities that I just wanted to highlight now. So I've sort of shown you this kind of depressing story, which is that 1, the climate hazards are increasing. 2, populations are becoming more vulnerable, where we've got aging populations or where we've got large number of younger people. We know that there's increasing number of people with pre-existing conditions, sometimes just through unhealthy lifestyles. And we know that the health outcomes are not looking good. For example, we can already find out, we can attribute health outcomes to climate change. So now let's try a few minutes of optimism and where there's some win-win opportunities for climate and health. And this, I think, is where policy really becomes important. And where policy becomes important, economics becomes important, and economists become more important. So I think we have a lot to say here, and there's a lot of space still to say things. So just a snapshot first of where the opportunities are. So why might it be useful to understand where climate change is worsening health? So that's some of the slides I've shown. I think firstly, it provides yet more evidence for policymakers to act on climate change mitigation, especially in global talks. And looking forward to COP28, there is now an explicit health day in COP28. So I think that's quite a win for the health community. That health is going to have center stage at the COP. And in the last 2 COPs I was at, there were WHO had its own areas, and there were presentations on health and climate change there. It's also understand why climate change is worsening health is critically important for trying to prioritize adaptation actions. So if we know where climate change is already affecting health, even better if we can undertake projections, which we can do. It enables communities and governments to start to build resistance and improve adaptation. And so, for example, it's important to look at hotspots as to where there's going to be multiple pressures on health. And another interesting, potentially exciting area is litigation. So we shouldn't get excited about litigation. We'd like to see less litigation, probably not more. But if we can attribute health outcomes, negative health outcomes, to climate change, and we know what's causing climate change is emissions and predominantly fossil fuels, then it strengthens our ability to litigate against loss and damage. It strengthens our ability to litigate against the big fossil fuel companies. And just the ability to litigate and the ability to be able to demonstrate attribution might put enough pressure on companies to reduce emissions. Or it might not, but we'll try to be optimistic. And then on the identifying actually on win-win opportunities, I'll just show a few slides on air pollution and air quality, active transport, healthy diet, and urban green spaces. And again, this is thinking about health and health policy outside of the silo of health ministries. So I think tackling heat and air pollution is one of those areas where there's clearly wins. This is just a photograph of Beijing. I took my daughters there for sabbatical in 2015, and sometimes the air pollution was just horrendous. And it got me really thinking, what am I doing? You know, bringing my children to such a polluted environment. That's when I sort of had my Damascene moment and really wanted to work on climate change and health. But what we do know is that the combination of heat and air pollution, especially for people with pre-existing conditions or the very old or the very young, is particularly dangerous. So the flip side of that is there's tremendous health co-benefits from tackling the combination of heat and air pollution. We know that lower income households tend to be more exposed to air pollution. So there's a real equity and inequality issue here. Air pollution is in the main falling over time. This is Beijing, and I know there have been huge efforts to reduce air pollution there, but continued reductions are proving more politically difficult. I'm just going to go into 30 seconds of econ geek. But what we're seeing in London at the moment, we have an ultra low emission zone, and it's in central London, and the mayor's trying to expand it. And it's supposed to expand to Greater London in about a month's time. And it's proving really difficult to expand from central London to Greater London. And this is an example of people who have the incumbent property right to pollute versus those who want the right to breathe less polluted air. And those with the incumbent right, people driving any car they feel like in the central London, often in congested areas, want to hang on to that right. And we can have some sympathy. If you're a low-income family and you've got an old polluting car, you can't afford a new car, you can't afford to pay the ULIS charge, and maybe you need to get your disabled daughter to her therapy session across London. So you really are going to be worse off unless the government targets to help you. But then there's someone with a daughter with asthma who has to get their daughter to school and has to walk in this polluted air. So these are not easy questions. And I think that's why having rigorous data and well-narrated data really matters. We can produce the data, and we need that. And you know, we need to know when there's high air pollution and high heat, how many more people are being admitted to hospitals? How much more pressure is that putting on the health services? How many healthcare professionals have to take days off work because they're sick and suffering? And so tracking this over time, tracking the implications, the pressure it's putting on our health services, tracking the people who are harmed is critically important for having a conversation about who has the right to what and how we're going to charge people if they lose that right. And this is just an example of the data we're tracking that looks at, I showed you some data before that showed heat over time with populations. But here we're showing again where we find infants and age over 65, they're exposed to more heat wave days than the global average. And it's increasingly so. So what are the policy implications? Well, globally and locally, we can invest in clean energy, we can divest from oil and coal, we can electrify public transport, we can provide clean household energy. So that's one way where we can just reduce the general everyday quantity of air pollution. Then on the other side, we can start to look at early warning systems, targeted health messaging. Who needs to receive that health message during those particularly polluted days? just healthier communities. Every slide I could say healthier communities, people who are just more resilient to climate change and the causes of climate change. And we could even ask ourselves, on those very polluted days, should it be that we ask people not to go outside and not to exercise? Or should it be that we actually stop people driving and say, if we know it's going to be a hot day, do we actually actively reduce air pollution by saying, no, you don't have a right to drive on this day? That's for our policymakers to decide, but I think economists, health economists, environmental economists contribute to that conversation. Switching to more plant-based diets can potentially reduce methane emissions, can potentially reduce our health impacts, but it's not easy to achieve. There's implications for emissions, animal welfare, farmer welfare, nutrition, and equity. I was on the BBC radio program called Farming Today, or the Farming Program, and I was really being pushed by the presenter, as an economist that I am, to advocate for meat taxes. And I just couldn't, because I said, we still don't have enough information on what happens to low-income households in rich countries, but poor households when you tax meat. So we want to tax meat to change behavior. Yes, basic theory. But if you tax meat, maybe a low-income household doesn't switch to tofu or doesn't switch to plant-based meat, but they still give their children the same amount of meat because they know it'll fill them up and they know it'll give them a lot of nutrients. But now they have less money to spend on fruits and vegetables. So it's not actually clear that a meat tax is going to do good. So what do? But one way or the other, we need to change either our diets or cows' diets. People say seaweed might be the solution, not for us, for cows. But there's some experiments that are able to reduce methane in cows. But these are not easy questions to answer, but we have to find a solution somehow where we consume less meat in high-income countries. Investing in active lives and active transport, it's something I often talk about when I'm asked, so, what can we do? Where are these win-win opportunities? So we know that increased physical fitness, reduced obesity, reduced risk of cardiovascular disease, wonderful nirvana, we can get this from people having more active lives. And indeed, in the UK and maybe in other countries, people are now being prescribed. Doctors can prescribe or being asked to prescribe, or they might prescribe. I can't remember where we are in the discussions, but it's talked about. So there are discussions on prescribing fresh air, prescribing exercise, prescribing joining an outdoor gym. And again, this is data we track in the Lancet Countdown. It's harder to go outside and be active because there's fewer safe hours to exercise outdoors due to warming. Now, in some cold countries, it may be easier because it's not so cold, but especially in the poor countries, those are the red dots, the potential activity hours lost per person per day is now up to more than 3 to 3.5 hours per day relative to a baseline sort of in the early 1900s, 1990s. And so we can see that it's with climate change, it's more important to be healthy, but it's harder. And so these are conundrums we have to face. And I think city planners, when they're thinking about how to ensure a healthy environment, if it's hotter, maybe at least if it's not so polluted, we can exercise outside. Urban green spaces tend to be the sort of the go-to, it's that or mangroves, the go-to multiple co-benefits, mitigation, adaptation, health benefits. So again, these are the kind of data we can track. But what we know is that, and I've got a graph of Europe and urban green spaces and a global one that's only at a national level though. But what we know is that whereas in high-income countries, we tend to have good access to urban green spaces, in low-income countries, there's far less access. So again, there's a real inequality issue here. Low-income countries are likely to be more harmed by climate change, and they're less resilient to climate change, and there's less adaptation. And so this is another area where, for an economist, it's relatively easy to cost how much it costs to increase urban green spaces. It's much harder to quantify the benefits and think how you realize those benefits. And then you have to ask who pays the cost, who reaps the benefits. Again, important questions economists need to ask. So I've overrun by a couple of minutes and I've just got 2 slides left. So these are just to summarize, and hopefully this will be picked up in the questions. But what do we know? We know the leading causes of non-communicable diseases. They're increasingly beyond the control of the traditional reach of the health sector. So I think there's an urgent need for us to start thinking about how we create a healthy living environment. And it is consistent with new concepts of health. And I think there's a really clear message that we need investments in healthy environments, and we need investments in healthier living, which will have health benefits of the country and contribute to global mitigation and nationally determined contributions. We probably need to transform our health systems to address this, to address socioeconomic, to address environmental factors. And I think we need to think about this across the life course, including healthy aging, but really healthy living. And we probably need to, when we think about investing in health, we need to think about investing in many other health determining sectors: energy, transport, building, agriculture, and urban sectors. And oh, on that slide, those pictures, I just put those pictures in. One is of an ambulance in a flood, so not being able to get to help people because of extremes of precipitation. At the bottom is the first zero emissions ambulance that was driven up to Edinburgh in COP26. I thought that was nice to take a picture of. And I thought I'd end with a photo of Beijing when there's no pollution, because it's one of the most beautiful cities when there's no pollution. So there's way too little focus on economic costs and benefits and other aspects of economics. But I think, you know, if we work together, we can do something good. So thank you so much for listening in. Thank you.
Thank you very much, Liz. And we appreciate your economic geekness, and also trying to put a positive spin on what I consider as probably the dismalest part of the dismal science, the notion of having to live with climate change. Now I'm going to call upon Joe to give us, not taking that with me, to give us a response from a health economics lens for 5 minutes, and then we'll move to Martin. But do stay with us, please, Liz.
Thank you, Paula. So I'm going to start with a question. Is climate change relevant to health financing? I hope in this talk to convince you that it is, because 1, it's part of the problem. 2, it can be part of the solution. But 3, to make health financing work for climate change, we have to break silos. So why is health financing part of the problem? Well, we know, next slide, please. Click on the first, thank you. Oh, I have a good. Thank you. That's easier. So yeah, we know that health systems are a big source of emissions, contributing to climate change. And that financing as a key input into systems and through the incentives that they generate, in part drive these effects. But also, climate change affects health financing as well. So we can see that it has macroeconomic effects. We heard from Elizabeth. It affects growth and it affects tax revenue. And this puts budgetary constraints on the health sector. But in addition to that, it also results in increased government health expenditure. Why? Because of consequences on the supply side, with climate shocks such as floods and heat that can damage infrastructure. It can affect supply chains. And as we heard, it can also impact health worker productivity. But there are also consequences on the demand side. The rise in climate-sensitive conditions and the injuries resulting from climate shocks, together with increasing numbers of people migrating within and across countries, results in surges in demand. And this demand in countries where universal health coverage is incomplete will result in additional out-of-pocket payments. And alongside that, we heard about the livelihood impact of climate change affecting income levels through rising food prices and lower crop production. So this together will result in additional catastrophic and impoverishment effects, which really risks threatening progress to UHC. But the good news is that health financing can also be part of the solution. So if we leverage the health purchasing, the purchasing function of health financing, we can generate incentives for climate conscious behavior at all levels of the health system. So for example, in health technology assessment, we can think about how environmental outcomes could be integrated to guide investment decisions in health interventions, as well as the inputs that go into those interventions. We can also revisit purchasing arrangements and resource allocation formula and integrate incentives to promote behaviors that support sustainability and resilience. In terms of the climate effects on households, we need to think about how to make financial protection mechanisms climate adaptive. So for example, we might think about how climate sensitive conditions could be integrated into benefit packages. And we may also think about how we can more formally link with social protection schemes. So for example, giving access to health insurance to social protection scheme beneficiaries. But we also need to make sure that the resources are available to meet that additional demand. And so we need to think about how public financial management systems can be made more agile, so that there can be flexibility in the allocation and use of budgets to meet emerging needs. Good news is that climate change also brings with it a whole host of climate financing instruments that can potentially be leveraged for health. So there's multilateral climate mitigation and adaptation funds. There's a loss and damage fund, which is currently being negotiated. But also at national level, there's the potential to leverage earmarked taxes from carbon tax, for example, and use that to support the health sector. But all these solutions will require us to ensure that there's alignment between climate and health goals. So what can we do? In order to achieve these solutions, we have to break silos between research, policy, and practice. And this will enable us, firstly, to measure systematically the health co-benefits of climate investments, but equally to identify the environmental and economic consequences of health investments. At the policy and practice level, we need to be able to integrate climate mitigation and adaptation indicators into health sector plans, budgets, and monitoring indicators. But equally, we need to mainstream health within climate adaptation plans, because this will facilitate access to climate finance for the health sector. It will also be really important for us as researchers to work together to design and evaluate financing mechanisms that can meet joint goals. And lastly, but maybe more importantly, by breaking silos, we can, this will lead to the methodological and the policy innovation, innovation and learning that we need to make health financing work for climate change. Thank you.
Thanks very much. Thanks very much, Joe. I am amplified now. Martin, would you like to come up and just for 5 minutes, give some of your reflections, direct people to your health economics paper perhaps, and then we'll open it up for a panel discussion.
Well, good afternoon, everybody. While hopefully my slides are coming up, it's a great privilege to be here. I'd just like to acknowledge the Palawa people of Lutruwita, Tasmania, as the traditional owners of the lands where I live and work. And I'd like to also just say what an honor it is to actually be speaking here in South Africa. This is a country I love very much, where my oldest 2 daughters were born, and it's just a fantastic privilege to be here. It's very difficult to have to speak after 2 such fantastic presentations, but it means I can speed ahead. But I would just say, as we gathered here last week, we saw worldwide temperature records being broken just last week. So this is moving fast. and that is one of the themes I'm going to talk about. I think both Liz and Joe have talked very well about the interactions here. We have really interactive relationships between climate change impacting health, health impacts health systems themselves impact climate change. I think that's been made very clear. So I've been doing some work over the last few years in this space, really trying to map out a little bit what do we need to do, and specifically as health economists, how can we start to engage with this work? And I was fortunate to get a piece in Health Economics earlier this year, which I'll put the reference up for you, where a couple of the diagrams I'm showing you are, and if you get a chance, it would be great to look at that. You may not agree with me, but I think it's a good starting point of how we can talk about this. The IPCC last year, for the first time, started talking about the need for concerted action on both the demand and the supply side of every sector of the economy. And in that spirit, I think it's actually really important in health that we start thinking about both demand and supply side. The debate so far in healthcare, particularly about green healthcare, has really mainly been about the bottom half, the supply side here, and really critical work on how do we decarbonize the healthcare sector itself? How can we produce healthcare in the most carbon minimizing way? But that is only half of the equation. We also have to minimize the environmental impact and the carbon footprint of the demand side of healthcare. And you can see here, there's a whole load of things, and they're the same things we've been trying to do my whole career, which is now quite long, but they all drive down. We have to actually have effective action on the social and particularly the commercial determinants of health. There's a whole lot of carbon emissions, other forms of pollution, which are actually due to harmful overconsumption, which we could get rid of and everybody would be better straight away. We need effective primary prevention so people don't get sick in the first place, don't need healthcare. We need effective chronic disease management once they are, so that the carbon footprint of the treatment that they're getting is minimized. And we need to minimize, drive out low quality care, overuse, overdiagnosis. And that way, hopefully, we can get into the intersection, or not the intersection, the point of those two triangles, where we've minimized all the avoidable demand for healthcare that we can, and we've minimized the production emissions of the healthcare sector. In this slide, don't worry, I'm not going to take you through every box, but we can take that demand and supply side and overlay that on the two key principles that Liz was talking about as well, which is mitigation. How can we prevent climate change or reduce climate change? And adaptation. How do we change and adapt our systems to the reality of the climate change impacts that we're seeing? And this just tries to put up a bit of a matrix of some of the actions that we as health economists specifically might be able to contribute to here. And one thing I'd like to point out is that, you know, economic evaluation and health technology assessment, which is what a lot of people in this room spend a lot of their time doing, is only one box in that. There's a whole lot of other stuff. And there are, I think, critical capabilities we've got that down the track we can bring to bear. If in a few years' time, countries and internationally, we're actually beginning to get serious about carbon budgets, well, hey, look, we're really good at optimal budget allocation issues, aren't we? How can we bring those skills that we have to bear on that? How can we really start to bring economic evaluation skills to bear on the project of adapting our infrastructure? Most healthcare infrastructure in most countries is going to have to be significantly upgraded, if not replaced, over the next decade or so for both mitigation and adaptation purposes. How can we help to do that? So I'll leave these with you, and as I say, to have a look at, have a think about those. But there's lots of many skills we have well beyond, I think, people's day-to-day that we could make a huge difference with in this space. It's also really important to understand that the institutional environment that we work in, the people we work with and for as partners, that's changing and moving very fast too. So at COP26, a couple of years ago, following that, 70 countries now have formal commitments to developing climate resilient and low carbon health systems. So lots of countries are on this train, and we as health economists need to get with the program. WHO is working focusing increasingly fast on this. Other institutions are following. I know that the World Bank is starting to work here. Mariana Mazzucato's Council on the Economics of Health for All, which recently produced its final report, gives some really challenging approaches here, new ways of thinking about this that I think health economists need to engage with. And we also now have a Lancet Commission on Sustainable Healthcare being led by Jodie Sherman from Yale and Andrea McNeil from University of British Columbia. They're both clinicians, but they've brought together this commission, and I've got the privilege of chairing the working group on health system transformation. And we're really trying to bring different economic perspectives, as well as health policy and health systems capabilities to bear in that work. As Joe said, we've got, coming out of COP27, we've actually now got the beginnings of debates on climate finance, loss and damage funds, climate financing being discussed at COP28, this focus on health at COP28 that was being discussed. We've also got a growing focus, including by many governments, on different conceptions of economic well-being, and the growing focus of how we move beyond GDP and GDP growth. So well-being economics, the European Parliament recently hosted a big conference called Beyond Growth, where they brought together many post-growth and well-being and degrowth scholars and activists. Quite different ways of thinking about economics are coming into being. And finally, slowly, much slower than we would all like, research funders are beginning to bring some money to the table. Just to conclude, how can we as IHEA really engage with this? Well, I think the first thing that I would say to you is you all need to recognize that climate change is going to exert an ever greater impact on all of our work as health economists. What you do, what you want to do, what you can no longer do is going to be impacted by climate change, and you need to get real with that. It sounds a bit bleak, but I think that's the truth. What we do will be changing fast. At this conference, we were able to talk about setting up a special interest group. That's really important. So we'll be telling you more about that as time moves forward. We particularly talked about developing a community of practice for people working in this area, for developing our linkages with other disciplines, and really getting some concrete goals and activities going. Finally, coming back to the fantastic opening plenary that we started this conference with, equity, diversity, inclusion is actually at the heart of this. Climate change and its health impacts is at its heart disproportionately going to impact the poor and people in the global south directly, as a direct historical consequence of the extraction and appropriation of benefits by the rich and the global north. It is the biggest equity problem of them all. So we need to front up and engage with that. And it's here, it's moving fast, it's going to be a lifetime of work. So I think we need to be making space within IHEA, within the discipline, for younger, newer voices, taking new perspectives and taking bigger risks, moving out of the comfort zones that we have liked to work in and taking some risks to drive us forward. Thank you very much.
Am I on? Okay, sorry. We've got a few minutes for some questions. I have some primed, but I feel you've heard enough of me. Anybody want to jump up? Unless you're a climate denier, but we actually have a response ready for that because we practiced that. Do come up to the microphone, which is just down here, please. Sorry, I'm also going to make you do some active commuting, which is all good for us all.
Sorry, didn't realize I have to line up. So I've done, my PhD work included environmental economics, and I've been working in global health. But we've talked at this conference so much about diversity within IHEA and in health economics. But then all of the presentations and the discussion today and all of the Lancet Commission and everything else we're talking about does not engage the global south as much. What are we going to do about that? Thank you.
Joe, a great question, and very happy to be put on the spot. I'm going to ask Joe to respond as coming from the university with tropical disease in the title.
Gosh, it's a really good question. And I'm not sure I have a good answer to it. You have a go. Liz, okay, Liz.
Yeah. Do you want me to say something?
Liz, do you have a response?
Yeah, I would first say.
And we can't hear you either, which is unfortunate.
Oh, I'm unmuted. Can you really not hear me?
No, you can hear me. We can hear you now.
Oh, you can. Okay. An excellent question. Keep asking that question. I'm not going to defend myself, but what I would say is the Lancet Countdown has started to open regional offices. We have an Africa office in Gambia. We have a Latin America office. We have a Small Island Developing States office. And if we get a next phase of funding from next year, those offices, I think we'll have 8 regional centers around the globe. And a lot of funding put into that. So the Lancet Countdown will be owned in those regional centers as well. So I think that will go some small way towards recognizing the point you're making, that the people most harmed by climate change in terms of their health will be in low and middle income countries, and we need much more ownership. I would just say my co-author, Shordish Gupta, his work that I profiled, he is from Bangladesh. So that's something.
Other comments? Oh, yep, we've got somebody coming down the stairs. Oh, and we've got somebody here already. So no, do go first. First and best dressed. Yes, okay. Please.
Thank you so much. I'm so honored to be here as a Chinese scholar. And also you mentioned so much from our country. So I'd like to see something for part of the solutions. I think that's so fabulous moment with such so great scholars together, and also some other stakeholders here. So I'd like to see something about that solution from the idea. The idea is so important for everyone here, not only the physical world, but also the mental world, I mean, spiritual world. So that's a combination. If this idea from all of us try to have a positive contribution, that's so fabulous. For our Chinese people, actually, I think the traditional Chinese culture is so great. That's so great, not only for Chinese people, but also for all the peoples around the world. So I think our traditional Chinese culture at least have 3 schools. One's Confucius, one's Taoism, one's Buddhism. So I think if we could combine all other traditional cultures in your country and combine with ours, they are so classical. Our ancestors, they forecast what happened right now. That's disastrous everywhere because of COVID-19. That's a sad story. We have no place to go. we must have lockdown, right? So how to make us have more freedom? Let us have equal rights, or we see, energy, everyone do a little bit. Our idea is more valuable. So I really hope we could benefit from our ancestors, that classical, including Bible, some other, traditional culture. We should respect that greatly, which is make us could have a great improvement. Just like we, as a cleaner in our room, we try to do something that could be messy, but still we could make it back, right? It is so neat. So hopefully with all our efforts, our world becomes much better. We have a bright future. Thank you.
Thank you very much. Another comment.
Hi, thank you. Thank you for the presentations. Stephen Jan from the George Institute. I was just reflecting on some of the sort of, I guess, underlying causes of climate change, and perhaps one of the biggest driver is obviously overconsumption and our lack of willingness to cut back on that. And the problem there is, I think, is perhaps a lack of self-correcting mechanism. The fact that, there's nothing there that really to tell us enough is enough. There's no pain associated with the pleasure that we get. And maybe the health impact is a way of Mother Nature's way of giving us that self-correcting mechanism, saying, well, this is a fairly sort of immediate way of moderating what you're doing. And perhaps therefore our focus should be less on climate change, health mitigation, and more about the root causes of climate change. And I suppose the analogy might be that, if it's like taking a painkiller to enable yourself to, run back out and play rugby again and get battered. And it sort of dulls I suppose, the natural price signal that we're getting from climate change. And perhaps we should not necessarily embrace the health effect of climate change, but in a sense, direct it in such a way that it enables us to design things that address more the fundamental causes of it.
Thanks, Steve. Liz, did you want to respond to that? I think it might come into the title of even behavioural economists in that sort of space.
So was that to me or to Joe?
No, Liz, did you?
Oh, okay, yeah. It's a really good point. I think, one of the things about asking people to address the fundamentals of climate change is it's a global public bad. And so, people tend to point their finger and go, I'm sitting in the UK, we're less than 1% of emissions. It's America's fault, or it's China's fault. Whereas at least when we look at the health co-benefits, we transform a global public good into a national public good when we're spending on actions that can improve health. So, and yes, behavior is a lot of it. How do we change behavior? Do we use it with carrots or sticks? From an economist's perspective, we can use price mechanisms, we can use regulation, or we can use nudge. And we probably need all three of them. We did that with trying to reduce smoking rates. But it's, I think that the good reason about going from a health co-benefits perspective is because then the benefits go to the national country. And then you've got, the mitigation contributes more broadly globally. So that's why it can help sort of drive action if it's a little more selfish, that it just benefits the individual country. But I think really, really good observations. And I thought just the comments from the person, I think from China, if I go to right, we have very unhealthy modern lifestyles in the West. And, sort of looking back at what we did better in the past, I don't want to look backwards, I want to look forwards. But I think in looking forwards, we did some things better in the past and some things a lot worse. So we have much better healthcare now, but it's not clear that we have better livelihoods.
Thanks, Liz. I'm mindful of time. So I might just take the prerogative to have the last question. So in 5 years' time, I understand I won't be holidaying in Spain, Turkey, or Greece. It will be too hot. I'm wondering if each of the panelists would like to reflect on where they would like to see the discipline. Also, a note to the IHEA board: don't have an IHEA meeting in July in any of those countries. It's also, in 6 years' time, say. Although we will be all attending a meeting that's well air conditioned. Where do you see the discipline, I guess, in 5 years' time? Maybe start with Martin and then Joe, and then we'll go to Liz as to whether, I guess, some aspirations perhaps from the environmental economist discipline as well. So, Martin.
Thanks. I mean, a couple, where do I think, coloured with a little bit of aspiration, I guess, of what would I like to see. I think, how can we call it, the distribution of work, of the kinds of things that health economists are working on will have changed quite a bit in 5 years. As I said, I think don't underestimate how quickly this is going to force change and move people into different things. I would really like to think, coming back to the questioner about the sort of maldistribution of who's working on this, I'd really like to think that we'll see many more health economists from the global south, not only working on this, but taking up the leadership positions to drive it forward. I think more broadly, I think as health economists, I would certainly like to see, and I think this is an opportunity for us to be more confidently co-leading policy with our colleagues from other disciplines. I think we have a lot to bring here, and I think we shouldn't be scared of taking that leadership role more directly. I also think, coming back to some of these other points, actually in 5 years' time, health economists will be much more familiar with some quite different schools of economic thought, which are starting to move us outside of very traditional neoclassical perspectives. And we're going to see really quite different ways of thinking about what is actually the purpose of the economy, because it's the purpose of the economy to support humanity and the planet, not the purpose of humanity and the planet to support the economy. And I think that's a big switch that we'll need to make. And finally, I think more of us will be actually working on more applied policy, possibly more directly with governments. Probably somewhat fewer of us will be working on very kind of theoretical, methodological research. And I think we'll be prizing people with flexibility and imagination rather more than perhaps now we prize super specialized research skills.
Thanks. So I think obviously there is this emerging work looking at the effects of climate change on health, which is great, but there were not very many studies represented at IHEA this year looking at climate and health. So we obviously want to be seeing more of this in the future. But we also need to be looking at the effects of climate change on health systems and health financing and access to care, quality of care. So this is something to think about for the future, not just documenting the impacts, but also designing and evaluating responses and actions to address these impacts. So how to build sustainability and resilience into the health system and evaluating the effect of different interventions that aim to do that. I mean, one thing that I learned, I was lucky enough to spend my sabbatical with a climate change research organization in Vienna. And what really struck me there is that a lot of the economists there, they're using climate finance as a tool to build resilience into the system. So they're looking at the macroeconomic system and the community system. And it really struck me that we need to be thinking about how to do that in health. So how can we leverage health financing to reduce risk and build resilience in the health system? Thank you.
Thank you, Joe. And the final word, Liz.
Oh gosh, I don't think I have anything to add. I think it's just really exciting that we're talking about climate and health and how economists from any area of economics can contribute to the conversation. I think we know that there's going to be warming for at least another 27 years. Even if we get everything right, things are going to just get worse until 2050. So mitigation is super critical, but building resilient societies is going to be hugely important. And I think just reflecting what I said before, and building off the idea that finance is absolutely central to that, Joe. We need far more resilient healthcare, far more resilient societies, and part of that is more just healthier people and healthier environments. And I think there's just a lot of scope for economists to do much better engaging in these. And I think I agree with you, Martin. I think we're all very applied economists, the three of us here, and I think it's exciting that there's a lot of us really working to try and influence policy and to try and provide information that policymakers find useful. And most of the population on the planet lives in a low and middle income country, as I said, the most affected. So it's not just focusing on those countries, but ensuring that we support scholars, early career, late career scholars from those countries to really be able to engage fully and equitably in this really important area. So yeah, thank you so much for inviting me to be a part of this. Thank you.
Thank you, Liz. You're very welcome anytime. Over to Cara, I believe now.
Let me just ask you to thank once again Paula, Liz, Joe, and Martin for a really stimulating discussion. So as you know, I'm the president-elect of IHEA. So I will start my term in January 24. I don't want to discourage anybody, but as in IHEA, you're the president-elect for 2 years, and then you're the president for 2 years, and then you're the past president for 2 years. So it's a long gig, but it's really quite exciting. And in that light, I want to take this opportunity now to thank our current president, Audrey Laporte, for her service. We won't see her again in this role when we get together again next. So thanks, Audrey, for all of your contributions to IHEA. So I am looking forward very much to working with our executive director, Di McIntyre, and the board to support IHEA to continue to really flourish as a stimulating and supportive and diverse and inclusive professional society that works for health economists and by health economists. My term will coincide with our next Congress, which will take place in 2 years' time. Not in Spain or in France, hopefully somewhere where it will be cool enough for us to go outside. So in that vein, I'd like to take the opportunity to invite Amity Quinn from the University of Calgary to tell us a little bit about our next Congress.
Thanks, Cara. Again, I'm Amity Quinn. I am from the University of Calgary. And the University of Calgary and the Institute of Health Economics are hosting IHEA in 2025 in Calgary, which is in Western Canada on the traditional territories of the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda. And I really want to thank the University of Cape Town Health Economics Unit for such a warm welcome to this conference. And I hope to extend as warm an invitation to you now to please all come to Calgary. We have a short video to share with you to show you some of the beauty and activities that you can engage in when you come to Calgary and the surrounding area. As you'll see in the video, we also have very beautiful mountains, but they're a little farther away than Table Mountain. And I also wanted to add, I've been so impressed with the commitment and discussions about equity, diversity, inclusion, and accessibility at this conference. And I know our health economics group is as committed to building on what has been established at this conference. I hope you get a taste of Calgary from this video, and please come talk to me after or at the closing reception if you have any questions.
got a little pinch in the heart there. I see my mother country depicted. So anyway, as we all know, events like this Congress happen because of the hard work and dedication of a lot of people. So on behalf of all present, I would like to thank our colleagues from the University of Cape Town and the Health Economics Unit for welcoming us to this beautiful city. In particular, Lisa Marie Smith, Vanessa DeRees, Dina Sinamovich, and Sue Cleary for hosting a superb meeting and giving us the opportunity to learn more about the work being done here and in South Africa and from across Africa, and indeed creating a showcase for all the excellent work being done by economists in this community. I'd also like to recognize our funding partners, the Bill and Melinda Gates Foundation, Euroqual, and the South African National Convention Bureau. I'd also like to recognize our phenomenal Executive Director, Di McIntyre, for her she's up front and wearing an orange shirt because I gave her such a hard time. For her tireless leadership and dedication, not just for this Congress, but in between Congresses, supporting us all. And it's been so special to have this Congress in her hometown, in her mother country. Thank you to the management team, Nicole Corr, Kate Foster, and Shayna Asgill for all the organizational support and troubleshooting along the way. The staff and students from UCT who provided all of us with directions and support. The team from the conference center, the security staff, AV specialists, all the people who ensured that we ate so well. And the daycare providers, the photographer, the fantastic artists who performed for us last evening. And I know I don't have to say this, but I'll say it anyway. Thank you again to our excellent plenary speakers and our panelists for encouraging us as a profession to step up and to do more to tackle the big challenges of our time. Thank you to our scientific committee co-chairs, Anna Balsa and Paula, and all the program chairs for putting together a high quality and exciting program. Thank you for me personally to the IHEA board and our past and president-elect Winnie Yip and Cara Hansen for their advice and guidance. And last but not least, all of you, the close to 1,300 people that came in person and the couple hundred that joined us online, presenters, moderators, SIG conveners, mentors. Thank you for sharing your work with us. And thank you for everything you do to build the health economics community. And so with that, I wish you all the very best in your remaining time in Cape Town. And I invite you to the reception on the ground floor for more excellent food and wine. And take care and see you all in Calgary. Cheers.